the proteasome itself, it really helps us unfold or get rid of misfolded proteins or degradation of different cells. We used to have garbage disposal in our sink. When you used to put food or products in there, if your garbage disposal is clogged, then everything backs up. That's kind of what's really going on in the cell itself, is that I'm building up these unnecessary proteins that should be getting rid of, and it actually causes apoptosis or cell death.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today, we're talking with Daniel Verina, nurse practitioner for the multiple myeloma program at Mount Sinai Medical Center in New York City, about the proteasome inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Daniel.
Well, thank you very much for this opportunity. I'm very excited.
Me too. I'm really looking forward to this. So to start out, can you give us a brief overview of the history of proteasome inhibitors in the field of oncology?
Absolutely. So interesting enough that proteasome inhibitors were initially studied in the potential for treating muscle wasting conditions, right? So we really were using it in a disease state that we didn't use it now. And then about in the 1990s, we realized that it actually had an anti-cancer activity in the preclinical trials, more looking at it from an apoptosis or cell death in cancer cells in mice models, sparking really kind of jettisoning us into the multiple myeloma arena, what could be the next steps. And the first therapy that actually came out was called PS341, which we all know now as bortezomib, or the trade name is really Velcade, which found to have good, promising clinical data and accelerated its FDA approval actually in 2003, which was used in patients who had relapsed refractory myeloma, not for newly diagnosed myeloma at that time. So I think from that standpoint, proteasome inhibitors was a springboard into newer areas of treatment in myeloma.
You've talked a little bit about the mechanism of action. Do you want to go into a little bit more detail about how these proteasome inhibitors work and how they work to fight cancer?
You know, everybody talks about, and I always make bad jokes. So proteasome inhibitors play actually a necessity in the role of actually cell survival, DNA repairment, and proliferation on a negative side of malignant cells. But, you know, the proteasome itself, it really helps us unfold or get rid of misfolded proteins or degradation of different cells. I look at it this way. Proteasome inhibitors actually inhibit the proteasome from breaking down these misfolded proteins and disrupting cellular processes, if we think about it from that standpoint. So really introducing, so I'm from the 80s, so we used to have garbage disposal in our sink. When you used to put food or products in there, a proteasome is to grind it up and get rid of it. But if your garbage disposal is clogged, then everything backs up and then the sink backs up and then you have to call the plumber. So that's kind of what's really going on in the cell itself, is that I'm building up these unnecessary proteins that should be getting rid of, and it actually causes apoptosis or cell death, really accumulating that P53, the 17P gene in the cell, inhibiting proteins that prevent cell death, which is the NF-κB, and really increasing ER stress in the cell itself. But it also helps kind of stop or cause inhibition of cell arrest or progression of the cell, preventing cells, cancer cells in particular, dividing very quickly. But we always talk about myeloma and blood cancers in itself, and we think about in solid tumors, we say angiogenesis and how that really promotes cancer growth. But interesting, proteasome inhibitors actually inhibit angiogenesis in the micro tumor environment in the bone marrow itself. So it actually disrupts blood flow that really helps grow tumor. So that's kind of where the mechanism of these particular cells work and how they actually try to decrease the cell growth in cancer or pre-cancer death.
That was fascinating and a really great way of explaining it. I was trying to wrap my brain around it earlier today, and I was like, that actually fits together perfect with what I was thinking.
I love the garbage disposal thing. I think it's one of the best analogies I could think of from my age.
You talked a little bit earlier about bortezomib. Can you highlight a little bit more information about bortezomib and the other agents in this class and how they're administered?
Yeah, absolutely. We're kind of combine a few of those questions because it is interesting thing. So bortezomib currently, or Velcade is currently indicated in frontline therapy. And like I said earlier, it was FDA approved in 2003, and it actually can be given either intravenously or IV or subcutaneously or sub-Q. And how it really works is it's a reversible inhibition of this chymotrypsin-like activity in the proteasome. So disrupting, again, that protein degradation and unfolding of misproteins. Over time, and I'm just going to talk off topic for a quick second for you, myeloma is this disease that at certain points they become resistant or refractory to the current therapy. We have 3 in this category of proteasome inhibitors. So the next generation of proteasome inhibitors is really what we call carfilzomib or Kyprolis. And what makes it slightly different is it has an irreversible epoxyketone proteasome inhibitor that blocks the cell or the proteasome from reversing back to allowing cell growth. It was actually approved in 2012 in patients who have relapsed for the first time or the second line therapy or even in third line therapy. Remembering kind of going back and just kind of putting together that these drugs, Velcade or bortezomib and carfilzomib, are also given in combination with other therapies like immunomodulators or the monoclonal antibodies. So again, looking at carfilzomib, and that's given intravenously, not sub-Q. But there is a third proteasome inhibitor that's actually on the market, and it was actually introduced and FDA approved in 2015. It's called ixazomib or Ninlaro, and it's the first and only proteasome inhibitor that's an actual oral therapy alone. So again, but that's given its indication in 2015 is indicated for patients who have been exposed to one line of therapy. So that's kind of a little trickiness in conversation. So they could get dexamethasone or actually see one dose of Velcade, and then we can have the patient do Velcade. Differently than carfilzomib, where the patient has to relapse either on Velcade or Ninlaro to be approved, because it's not really used in frontline therapy except in combination for high-risk patients.
So you talked about, especially around the IV, the subcutaneous methods, but thinking about some of the issues you can have with the oral agents as well. Are there any administration considerations that nurses should be aware of when administering a proteasome inhibitor?
Absolutely. So when we kind of look at both structures, so let's talk about, we can kind of combine Velcade, looking at it intravenously and sub-Q. So interesting enough, it was indicated initially as an intravenous therapy, given usually generally 1, 4, 8, and 11 in combination every 2 weeks, out of a 21-day cycle. But it actually then found the same efficacy if it was given sub-Q. So when you give IVs, you want to make sure you have a very good intravenous IV catheter. It has good blood return, no swelling at the site. The same way when we give anything that's either subcutaneous, you want to make sure that the skin is not broken, there's no infections. And again, always using aseptic therapy alone. But you need to kind of keep in mind that with any kind of proteasome inhibitor, generally, it needs to be no less than 72 hours separated from each other. So it can be longer than 72 hours, but not shorter than 72 hours from each dose of the therapy itself. Kyprolis actually, because it's intravenous, again, having a good site. So it can be given with any kind of central line therapy. So patients have metaports or anything like that, or an intravenous catheter. Again, keeping a close eye on that. And there's different rates of carfilzomib IV. Usually it's given over 20 to 30 minutes as a carfilzomib is an infusion alone. So those are good. Making sure, again, always having good IV blood return. And then Laro has its own trickiness, right? So it's an oral agent. So we know with any kind of oral agent, we're going to definitely have gastrointestinal upsets or issues with that. So from nurses' standpoint, they should be really doing a good assessment on how well is the patient tolerating it. Are they having nausea and vomiting? Are they having a lot of diarrhea before continuing the therapy and making sure that the patient can tolerate it alone? I think in general for nurses and I don't like to use the word nurse. I have to say, I call everybody a healthcare provider because we're at the bedside and we are providing good care for our patients in all cancer settings alone. When we look at administration, we also want to make sure that we're looking at the blood counts, right? Because proteasome inhibitors are well known for causing thrombocytopenia and neutropenia. So making sure that the patients do meet eligibility for the treatment for that day. And they do have anemias or lower in red blood cell counts. You want to make sure that because of these therapies that the patient has no symptoms or infections going into each therapy for that day. We came out of COVID, but the flu and cold season, I think is 24/7 now. Everybody has the flu. Doesn't matter what season it really is anymore. So we really want to make sure the patient doesn't have any kind of respiratory RSV. And we also starting to see a lot of GI toxins, right? Like the norovirus or salmonella. So again, good upfront assessment, making sure their labs meet renal impairment or hepatic dysfunctions in our patients. Are they drinking enough fluid? I make a joke. I tell all my patients I need to drink, but we work in healthcare and I think we're not allowed to have a cup more than an ounce in front of us. In reality, we tell our patients to drink water. We don't drink the water itself. So we really want to promote any kind of therapy, whether it's a proteasome inhibitor or not. Everybody should be drinking at least 1 to 2 liters of fluid a day, unless they have other cardiac limitations or on hemodialysis. But one thing, and I think that I can only talk for myself, is a blessing that I have an excellent PharmD at Mount Sinai, and they really examine our patients and the therapies they are on and other drugs that they're being prescribed. And you want to make sure that the patient has no drug-to-drug interactions, especially medications that metabolize in the CP3A4. And because you don't want to have them induce it, or by having inducers, you're intensifying the therapy alone. So again, pre-screening and having those and making sure there's no kind of interactions with our patients.
I had a lot of takeaways from that, but there are 3 that I want to follow up on. To your last comment, making sure that we have a full list of the medications that the patient is on so that we can identify the ones that could be inducers to this. And then going back to a couple of your earlier comments where you have to make sure that there's at least 72 hours between each one of those doses. Thinking about from an ambulatory perspective, if the patient's getting this in the outpatient setting, so making sure that they're not scheduled for their next visit for this. Maybe they got their dose at 5 in the evening and they're scheduled at 8 in the morning on day 3 or 4, that 3-day later period. So paying attention to those appointments. Same thing as thinking about if it's an inpatient nurse with all of the times of their medications being put on at a certain time, that you pay attention to when their last dose was so that you're not giving it too early.
Absolutely. I think that's one of the greater challenges because patients like to change their schedules. So sometimes they get it at 9 a.m., sometimes they want it at 2 p.m., sometimes they want it at 5 p.m. It is up to us to have it. And generally, and the pharmacy is very good at giving the plus or minus like 2 hours in either direction so that the patient can have 70 or 74 hours alone. It's important to keep that in mind. But when it comes to the oral therapy, and I'm kind of piggybacking what you said, we don't really change it by 72 hours. Ixazomib is given weekly as an oral therapy alone. And it's important for the patient to, if they did have nausea or they vomited after taking the therapy alone, that they don't take another pill because they think they missed their dose by having emesis. And actually, it's recommended that the patient hold until the next week before they take the drug alone. And so that's something that we need to educate our patients on.
That's a really good point. I think you've touched on a lot of this, but what are some of the more common toxicities and adverse events associated with proteasome inhibitors?
If we take I call the big broad stroke of the umbrella of them, the proteasome inhibitors are well known causing peripheral neuropathy, this numbing and tingling, whether it's in the fingers or toes. Most times it starts on the toes and intermittently on the fingers, but it's kind of keeping a close eye on those associated toxicities alone. I think I love the word fatigue. I think the whole world is fatigued. So I don't know if that's true or not, but patients who are on chemotherapy are always fatigued. So again, adding that to that. And specifically when you talk about Velcade, whether it's IV. So IV gave more peripheral neuropathy versus sub-Q. The toxicity is a little bit less once we give it sub-Q. We do see thrombocytopenia, which I said earlier too, that it is common in all three of those, whether it's given IV, sub-Q, or even in the oral standpoint, that you're going to see these toxicities alone. But if we tease out each one, so when we start looking at Velcade, interesting enough, it can cause hypotension, cardiac failure, and sometimes pulmonary edema. Switching that up a little bit, and what makes it slightly different, carfilzomib, again, fatigue, but a lot of times we saw, even in the clinical trial, that there was a lot of hypertension or cardiomyopathies or arrhythmias that we saw with carfilzomib and the different dosaging that they have indicated from the FDA. So again, monitoring these hypertension and making sure the patient comes in the door the right, or heart failures. And we'll talk about how we can manage those later on. In the oral standpoint, and I said earlier in this discussion that yes, there's GI toxicities, nausea, vomiting, or diarrhea, but we see diarrhea, but our non-hematological side effects is rash. So it can cause rashes. And because it's oral, very different than like a skin rash from a sub-Q injection from the site, it causes this generalized rash. It can be on the lower extremities or even the arms or chest. So those things that we do see a little bit different than most other proteasome inhibitors in the IV or sub-Q arena itself. We do see swelling, like water retention. I mean, I always say I'm bloated, but in reality, by the end of the day, our legs are swelling, but we do see some swelling occur. Now, can that be from the proteasome inhibitor or some type of steroid that the patient's getting in combination with their therapy? The answer is absolutely true. But we also want to keep in mind another adverse effect, and especially in myeloma, our patients come in the door already immunocompromised just by the disease state alone. But now I'm giving them therapies that can drop their neutrophil count, so neutropenia and thrombocytopenia. So there are a higher risk of having serious infections, even including like pneumonia or having outbreaks of herpes zoster or the shingles. So again, those are the kind of the big side effects that we look at.
So you're looking at, you've got the side effects, but then you mentioned, zoster or other infections. They're kind of like a secondary toxicity in relation to what the drug itself is causing. And I think it's important for people to remember those things, that what's the downstream effect of you having this?
Absolutely. I totally agree. I think in myeloma, and everybody's holistic. You're not just looking at the cancer cell itself. You're looking at the person in front of you and making sure that they're tolerating everything from top to bottom, whether it's infections, hematology, cardiac, and are they eating well? Nutrition takes a point in that.
We talked about the toxicities. What are some of the pharmacology related strategies that could be used to prevent or manage those toxicities?
I love this part because in myeloma, I think we're all chefs. We're not bakers. Nothing is really programmed. It's a pinch of this, a pinch of that. And we can really figure out how to, and everybody's individualized, right? One person can never get nauseous and the next person takes one dose and they have intractable nausea or vomiting. I look at it from this standpoint. When you look at peripheral neuropathy, whether it's intermittent or not, and I think from a nursing standpoint, that's something you want to keep asking the patient. Do you have peripheral neuropathy? Is it impeding? And this is another point I forgot to make earlier for you was, does it impede on their daily lives? Can they still button their shirt? Can they tie their shoe, or can they handwriting change? Or is there issues with handwriting? Can they tell hot or cold from waters, right? Getting into a tub, feeling the floor. So with peripheral neuropathies, there's two categories of therapies that we can use. There's anticonvulsants. I know that sounds like they're having a seizure, but it really, some of this gabapentin or pregabalin are two therapies that are available to help kind of mitigate or decrease the sensation of peripheral neuropathy. We want to make sure that we're stopping it earlier before it gets worse, because sometimes peripheral neuropathy can be permanent and cause damage for the patient if it impedes in their lives. And other toxicities or even management is stopping the drug, making the decision that the peripheral neuropathy has gotten to the point that we need to stop the therapy alone without continuing forward. That's generally across the board. Skin rashes can be from hydrocortisone creams, from the side of injections. It's red. It can be irritating, but we can do that. When it comes to carfilzomib, one of the side effects, like I mentioned earlier, was hypertension or high blood pressure. In the clinical trials, patients used to get IV fluids pre and post carfilzomib infusion because there was the thought process of tumor lysis. So they wanted to make sure that the patient was properly hydrated and decrease the risk of tumor lysis. But we have to make sure that we see the patient that's in front of us and make sure that if there is no risk of tumor lysis, do they still need all of this heavy fluid hydration pre and post for that? They could use it maybe for the first cycle if they really do have high disease burden. But again, making sure that the person can tolerate the fluids, that they don't have any cardiac history like heart failure or cardiomyopathy coming into the door, or AFib and flutters in those standpoints alone. And making sure the blood pressure is properly managed. When the patient starts the therapy, their systolic blood pressure should be less than 140 because carfilzomib can raise the blood pressure after infusion. And usually the symptoms do last 24 to 48 hours after the infusion alone. So again, making sure that they have a good handle on their blood pressure. They have a cardiologist with them, not with them next to them. I bring my cardiologist to my cancer center. No, but in reality, you want to make sure that they are followed up by a cardiologist. Because carfilzomib also has this hypertension or cardiomyopathy potential, you want to also make sure that they're getting echocardiograms or some type of monitoring of the heart structure alone. Every physician that I've worked with has different opinions of that, but you always want to get an echocardiogram up front with the patient before they start carfilzomib. That's kind of how we do it in our practice. And then we tend to do it here. Now, every institution is slightly different. So I'm not giving a prescription of having this done all the time, but we do it every 3 to 4 months on the patient. Or if you feel it's necessary, you want to make sure that the patient is being monitored at the time to get an echocardiogram. Also looking at blood counts like pro-BNP and troponin levels alone. And again, like I always said, if the patient has shortness of breath or symptoms, hold the therapy. I think that's one of my biggest messages when it comes to cancer treatments and educating other healthcare providers, or even educating our patients and their caregivers or their care partners with them, is that we need to sometimes hold the therapy for safety. It is better to hold the therapy and then treat the symptom, or just not keep giving it so that they have worsening symptoms. When it comes to ixazomib, which is the oral therapy, like I said earlier, again, we give antiemetics up front. If they're having diarrhea, you can do antidiarrheals. I always do some type of stool sampling if they have it, to make sure that there's no infection in the stools. Like I said earlier, the norovirus has been rampant lately and things like that. Antiemetics, how I tend to give it is that, because it's oral, I tend want my patients that they can take some type of anti-nausea medication 30 minutes in the morning, then they can eat. And then 2 hours later, they can take the Ninlaro, because Ninlaro has to be given or administered by the patient at home, either 1 hour before food or eating or 2 hours after eating. But I tend to tell them that they should take the anti-nausea medication, have a little breakfast, and then 2 hours later, take the Ninlaro. And it seemed to tolerate it very well. For rashes, like everything in life, you could use topical creams. If the rash is really systemic or throughout the whole body, legs, chest, or back, hold the therapy. Sometimes we do get a derm consultation, but you can also try systemic therapies or steroids if necessary alone. I think those, again, like I keep saying, hold the therapy is really important going forward.
You talked about holding therapy, and I think this leads into the next question I have for you, because you said about how you have to talk to the patient in a way that helps them understand that you're holding it for them because of their symptoms. Because the other side of that we know from our patients is that now I'm not getting my therapy. So does that mean that my disease is not going to be controlled? That's a piece of patient education that I think we always have to do when we're holding medications because of symptoms.
I totally agree. And we, unfortunately or fortunately, in myeloma for years, have told our patients, you're always going to be on therapy, right? That's kind of how we've always presented the patient. You're always going to be on some type of therapy for years. Very different than other therapies where, they may stop in solid tumor after 2 years, they stop the therapy. So the patient is leery because they think the disease is going to come back right away if I hold their therapy alone. So yes, it's educating the healthcare provider, the nurse, the APP, the advanced practice provider, and then really educating the patients, the caregiver, and also the patient themselves, and really supporting them, saying, it's okay. We can get through this, and we're going to make sure that it's safe to restart the therapy. Or what's the other hand? I may have to change the therapy because you're not tolerating this, right? One of these kids does not always belong here, in the sense of like the square peg doesn't fit in the round hole doesn't mean it's wrong for everybody. It just doesn't fit for you. And it's okay to hold and change.
What are some other primary patient points that you would want to communicate to both the patients and then their caregivers about these inhibitors?
I think in healthcare alone, there's a tremendous amount of information besides Dr. Google or Yelp and all the, Mrs. Instagram and all of that that's out there. I think it's our point to always reinforce the side effects that each therapy the patient is getting, and asking the patient, are they similar? Giving them documentation from the institution showing the side effects alone. I always tell my patients, because in our institution, some of my patients, we're more of a consult service. So they come to us for guidance. And then I say, keep a log, keep a book. Let me know when the symptoms happen. Are they happening the day of treatment? Are they happening 2 days later of the treatment? Are they having a week later for the treatment? And being able to kind of guide which therapy is causing some of these adverse events or side effects alone. So making them have calendars. When did you take the drug? When did you get your last infusion or your last sub-Q injection? Always talk to your care team, whether it's in an academic center or next to your house in the community. Let them know everything that's going on. I always tell my patients, when it comes to cancer treatments, it's not the time to be heroic. This is not the time to be stoic and say, I can do this. Yes, we can do this as a team, but you have to fill me in on the information so that I can make the best decisions going forward for you, your caregiver alone, because the burden on them is probably tremendous, and then moving forward alone. Other things, and myeloma, if you don't really know myeloma is considered a more mature adult disease. I never say elderly because I'll probably be there tomorrow. So I always use the word mature adult. The common age of diagnosis of myeloma is 69 years old, but we are starting to see our patients younger, in their late 20s, in their 30s. So one of the other educational components is really fetal toxicities, or discussing contraceptive use in patients that have the potential of pregnancies. So again, bringing that up and saying, what is the fetal toxicity of each drug? Did you go through menopause? That's always a good question. I love asking my 80-year-olds that question. Are you in menopause? And they stare at me. I go, when was it? And they go, I don't remember. It was so many years ago. But again, always bringing it up. Are you looking to have children in your 20s and 30s years old? What is your goal? Again, keeping that in mind. So really bringing it forward, that fetal toxicity conversation or contraceptive use conversation, I think is, from a healthcare point of view, is discussing it with the patient and their caregivers alone. I always say exercise. Okay, I don't exercise, but I tell my patients they need to exercise because that helps them in well-being, being able to say, I can walk 5-10 blocks. Because with carfilzomib, you want to make sure that they're not getting shortness of breath from daily movement. So I'm in New York City. Everything's pretty much flat. So if I ask my patients, how far can you walk? They'll say, oh my God, I can walk 15, 20 blocks with no problem. But then I say to them, but if you go upstairs or if you go up the subway stairs, how do you feel? And that's when that changes. You say, oh, I feel short of breath. I'm tired after 6 or 7 steps. And then when you look at our patients in the community, there are mailboxes that are 5 miles away down a hill, and then you got to go back up the hill to get your mail. So asking them, how did you tolerate walking down your street, around your block, going to the grocery store? So again, keeping those in mind and communicating. And then again, really asking those daily activity questions. What has changed? Is it the handwriting? Are you unable to walk? Is the natural gait that they had prior, has that changed? Are they looking like they're stepping very cautiously because they can't really feel the ground because of the neuropathy? Do they feel like when they take their socks off, they're still wearing their socks because of some of these side effects like peripheral neuropathy? So again, it's us really bringing the patient to be, I always say, being transparent, vomiting as much information at me, because my philosophy is every statement they make or every question they have is new. I may have heard it a million times because this is what I do every day, but it's new to that patient. So it's new to me at that moment. And that's the great opportunity to give education or support our patients.
It's an excellent way of putting it. It's new to them. And because of that, it's new to you and your perception of it as well. So how can pharmacists and oncology nurses collaborate to manage those adverse events and toxicities, provide patient education, serve as a trusted source of information so they're getting it from those trusted places as opposed to Instagram or Dr. Google, as you mentioned?
Dr. Google's the best.
I know.
No, I'm just joking. So please don't Google me. No, but in reality, I think it's a collaboration. I think we always say it takes a village to raise a child. It takes a village to care for a patient who has cancer and the caregiver who takes care of that patient. It's not the patient who only has cancer. It's everybody around them that supports them that has cancer. So it's kind of having that discussion. Our pharmacist actually goes down when the patient is newly diagnosed and it's their first time getting treatment, visits them, goes over all the therapies, all the side effects and how they should take it and support. But then they also go down on a rotational basis and go around and do touch points to the patients every time they come in through each of their cycles and may see a person every 2 or 3 cycles looking at that. So really kind of putting it together and saying, how do we best support our patients? And giving printed information. Every institution is slightly different. Some people use in-house support material, the nurses, the infusion center, the care nurses, actually in the clinical side point, we give the patient repeated information. If it is allowed, a lot of the pharmaceutical companies do have branded information that also talks about these side effects. But really importantly, there are 2 large organizations, 3 actually large organizations that can help support our patients. There's definitely ONS. I know this is an ONS program, but in reality, it is very good amount of information in ONS on side effects and side effect management and how to actually talk to our patients. But specifically when it comes to the proteasome inhibitors, we have 2 other large organizations called the Multiple Myeloma Research Foundation, or MMRF, or the International Myeloma Society, the IMS. Are 2 phenomenal organizations that give out non-branded therapy information on caregiving, but even on all the therapies that our patients get and signs and symptoms of management.
We've covered a lot of information. What does the future look like for these agents and their role in the rapidly changing landscape of cancer care?
I grappled about this question because I thought about it and I said, where are we going to be now? I think proteasome inhibitors currently will stay around for quite some time. We still go horseback riding. We haven't killed the horse yet. So, besides jumping into the car, but proteasome inhibitors will be there for all patients because, and I'm going to talk off topic for a quick second. We do know that we have these new agents coming out, these T-cell engagers, right? Looking at antibodies and engaging our T-cells, whether it's in sub-Q injection or it's given as a one-and-done therapy. And we are looking at them in clinical trials only as giving them upfront for patients who are newly diagnosed. But, like I say in everything earlier, not every therapy that is available is appropriately for each patient. And that's just to say, because of their disease burden, because of other comorbidities that the patient may have, may not be the safest way to approach this. So I think proteasome inhibitors will be still available down the line for many, many years. And they'll be there even if we do immunotherapies or these cellular therapies up front, if the patient relapses, the proteasome inhibitor is always still available. So we're not going to kick it off the shelf. It will still be available to take off the shelf.
Exactly. We're still using those medications, the chemotherapy that we started with, and we'll continue to use them.
Absolutely. The steroids have never gone away.
Exactly.
The Mary Poppins of myeloma. Everybody loves a little steroid.
Yep. Daniel, it's been great talking with you. I have a few very short, quick questions for you that we ask all of our. Thank you. That's the word I was looking for. What are some
you now?
Yeah. What are some common misconceptions about proteasome inhibitors?
I think sometimes the thing in therapies, it could be like they cause such severe neuropathy that patients will never tolerate it. And I think that's a misconception. I think we just have to be diligent at evaluating our patients up front and really placing that point there. Or it's not for everybody. It really is for everybody, for all ages, from newly diagnosed in their 20s to newly diagnosed in their 95 years old. So really, I don't think there's much. It's really education and research and understanding.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think we answered that about really the T-cell therapies. I think we're nervous about where they're going to be placed, but I think there's not much to discuss in that reality that we're afraid to talk about. I think sometimes we're nervous how to give it and where we can give it in the body. Like I said, sub-Q injections can be given either in the abdomen, in the thighs, or actually in the arms alone. And sometimes people just always keep giving it in the same spot. Or they're just afraid to ask the patient how they feel because they think the patient's not going to want to stop their therapy. So it's really teasing that part out.
What's some additional training or education that oncology nurses need to stay current on this topic?
I think research. I think going to conferences, especially in ONS and other conferences across the country, is very important to understand this particular therapy, its role, and the side effects that have to go on that the patients need. It's also reading, looking at up to date, looking at the most current information or Medscape and things like that. I think also are what nurses are. We live in a very, I don't even know what to call it. We live in an Instagram world, right? Where nobody had the attention to read a full article can be challenging because we're very busy. So it's really trying to find the best resources that can give us a very short bullet point blip about a therapy. And then also in institutions, I think one of the biggest, I don't even know how to say this. I think one of the missing points or things is nurse education. We don't have enough nurse educators in healthcare, especially in the cancer center with all the new therapies coming out, and having them being able to reinforce some of this education to infusion nurses that are maybe new to coming into cancer. They're only 3 years out from nursing, and now they have to learn this particular therapy and the disease alone. So it's really, as a healthcare profession, as a nursing profession, I think we have to have stronger educators, more educators. They're very strong in their knowledge. It's having them being able to be accessible and not being less accessible.
So you talked about the Myeloma Foundation and a couple of places. What are some additional resources for patients and providers who want to learn more?
You forgot ONS.
I did. I know.
But it's really those big, especially in myeloma, it's really the MMRF. I always say the IMS and definitely oncology. There's the Chemo Foundation. There's the Leukemia, Lymphoma, Myeloma conferences and things like that. I think those are important. There's the American Hematology Society, or ASH, that puts out a lot of publications on information about therapies that are available for our patients and for the caregivers and for our healthcare providers, nurses, and APPs.
Thank you so much for talking with me. Do you have any additional comments or anything that you'd like to add?
I think we talked about a lot, and I hope it was extremely informative for the audience tonight, or today, or whenever you're listening to it. But in reality, no, I think in myeloma, but I'm just talking general, you're absolutely correct. Like you said earlier, that the cancer world is evolving very quickly. We're on a treadmill with the newer therapies that are coming out. And it's, I think, one of the greater challenges for healthcare providers is staying abreast of what is new, what is out there, and the side effects. And it's just really our job is to really be able to care for our patients alone. I think I'm going to talk off topic, and I hate saying this, it's us learning how to listen to the patient going forward. We have tasks to do. We all have tasks to do in our lives, but we have to take a breath, be mindful of who's in front of us, listen to them first, and then be able to talk to them and care for them up front and see what the symptoms are. So I think that's what we need to do. We have to take a breath in cancer.
That was so beautifully said.
That was really good.
Thank you so much. And I hope you have a great rest of your day.
You too. Thank you so much for this. I'm glad.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.